Welcome to this episode of Pain Conversations from AFASAIR. I'm Chris Bridgeford, the founder of AFASAIR and chairman of the AFASAIR Trust. With me today is Joe Parsons. Joe is a 23-year-old PhD student at the University of Manchester who's studying breast cancer metastasis. He is also a chronic pain sufferer of 8 years with Ehlers-Danlos syndrome. This means he has constant pain in his back and neck, sometimes spreading out to other joints in his body. Having seen specialists in rheumatology, pain management and physiotherapy, he was told that the future of his condition would be management as opposed to anything curative. As part of his self-management therapy, and fueled by his frustrations, he decided to write a book. This is now developing into a one-stop shop for everything you could want to know about chronic pain and how it affects the day-to-day lives of individuals. He's also working to write a new standardised pain management programme for the UK, and this would provide much better support for patients and would better prepare them for not just managing their pain, but for managing their life around their pain. And he has asked me to join him on the project. Well, thanks for agreeing to speak to me, Joe. You suffer from a condition called Ehlers-Danlos. Could you let me know what that's about, what effect that has on you and the symptoms?
Yeah, absolutely. So Ehlers-Danlos, there's more types than I can count. I think at last count there were 13, and now that seems to grow every week. The type that I have results in me having sort of, I like to think, the worst of both worlds. So some of my joints are hypermobile and some of them are hypomobile. The reason for this is thought to be that there's mutations in connective tissues. So it basically means that your joints aren't really designed to function how joints are. So that means that my body is putting in a lot more energy. The muscles around my joints are having to use a lot more energy to support the joints. And so it means that I'm draining a lot more energy. So that comes along with chronic fatigue syndrome as well. Day to day, the symptoms will be pain throughout my back and neck. This can sometimes, on bad days, radiate to hips and other joints like the knees. It does mean as well that I have very fragile joints. So I throughout my sort of youth, I've been very athletic. But as I've now got older and these symptoms have worsened slightly, as I've tried to remain athletic, things have started to go wrong. So my ankle sort of fell to pieces, and then I tore my patella tendon because the joints just aren't really strong enough to support what I want them to do. Yeah.
Most people, when they headline Ehlers-Danlos, seem to pick on the double-jointed effect of it. Is this true?
It really depends on who you ask. So for me, certain joints, I do have weird traits that were actually the ones they use to characterize the Ehlers-Danlos. So you have things like touching your thumb to your wrist is sort of one of the classic ones for hypermobility. One of my friends has Ehlers-Danlos as well, and she's basically a contortionist with the way that she can sort of fold every joint. So it really just depends on the individual, because like I say, some of my joints are really hypermobile, and some of them are the exact opposite. So in the sense of as well, one of the joints in my spine, when I was seeing musculoskeletal doctors, they were saying that really it's one of my discs that seems to be far more full of collagen than all the rest. So when I lean forwards, I don't bend with like a smooth curve. I just sort of fold. So yeah, there is a bit of truth in it, but it just depends on the individual.
How long have you had this now?
So this started to show symptoms when I was 15, so that was 8 years ago. And then obviously been through every doctor under the sun since then.
Was it quickly diagnosed?
No. So when I was 15, they thought it was growing pains, persisted for about a year and a half, and they finally agreed to have a look at what was going on. So I got referred to rheumatology. They scanned me and decided that from an MRI that I had something called Schumann's syndrome or Schumann's disease, which is where the discs in your spine grow at different rates. So you end up sort of arched forwards a little bit with your shoulders sort of hunched over, a bit hunchback. and they decided that also I had mild scoliosis because a piece of my right hip was naturally missing. So one leg was longer than the other. So I was sort of bending to compensate. So I had orthotics fitted, and was taught to walk in a different way. And this sort of, it improved the straightness of my back. My back now looks perfectly healthy on scans, but it wasn't until, I was 21 that they diagnosed Ehlers-Danlos. So it was 6 years of back and forth.
It doesn't seem to have stopped you. You're a PhD student at Manchester University. What sort of methods do you use to be able to carry on with your studies?
So there's several ways that I sort of go about it. I've always been, in my life, there's always been a passion, and that hasn't always been the same passion at all points in my life. But from about the age of 15 to 20, I was really passionate about music and performing. From the sort of age of 20 to now, I was very passionate about basketball. I've since developed a passion for dance. And so it's having these passions where I can see improvement, because often with the pain I'm seeing sort of, it worsens at times, and I'm getting more flare-ups, and it's getting more painful, and it's becoming more mentally tough. And so having an area of my life where I can see improvement relatively quickly, so I can get better at dancing, I can get better at basketball, etc., it gives me that outlet to feel like I'm still progressing. And I think that's what allows me to feel mentally stable enough to cope with the sort of the physical aspect of it.
Is there a medication component to your treatment? Do you take many pills?
So at the minute, I'm taking no medications. I was first off told, as everyone is, take paracetamol, and that's been a recurring theme throughout the past 8 years. I've been given, obviously, gone through the scale of cocodamol, codeine, been offered things like gabapentin and oromorph, and wanted to avoid them from things that other chronic pain sufferers have said. They said that it has been detrimental to their abilities to, it makes them feel drowsy, and it's sort of things I felt I couldn't afford in my profession. I wouldn't be allowed to work if I was feeling drowsy or nauseous. But I did for a while take amitriptyline, which is commonly used as an antidepressive, but it's used for neurological pain as well, because this was when they still weren't sure what it was, and all I got from it was some odd hallucinations when I was sort of going to sleep. But other than that, it didn't really help. So I've been on various anti-inflammatories as well, and they looked to put me on anti-TNFs, but decided against it because they didn't think the inflammatory markers were high enough. But yeah, so at this point, I'm trying to do it without any pharmacological assistance, because I assume that maybe in the future it will get worse. So I want these heavy dose. I know that's not a good assumption to have, but in case it does, I want to have these heavy painkillers so that they still have their full effect in 20, 30 years time, rather than taking them now and maybe building up a tolerance.
So I would imagine you're a great advocate of self-management then.
Uh, yes and no. So yes, I think it is essential for anyone with chronic pain to try and look for ways that they can improve their own quality of life, and you can't always rely on the next GP appointment, the next rheumatology, the next neurology, whatever it is that you have to go to. I do think that there needs to be a much better dialogue between doctors and patients. I think you and I have spoken about this in the past. The fact that doctors aren't reading your notes before you arrive, and you spend your whole appointment talking to them about your history rather than actually working out where to go next. It feels like a waste of time. So I think there is definitely improvement to be made on the clinical management of it. But yeah, for me personally, self-management has been my main sort of way to get through it. And as I say, that's been from trying to stay fit and healthy in other respects, trying to stay active, trying to do things like yoga, and do as much as I can to strengthen the joints that are a little bit wobbly. And yeah, I think also I like to practice something which I call mindlessness. So everyone knows about mindfulness. Everyone knows about this concept of having greater sort of mind-body interaction and being able to dissociate yourself from pain and things. But I think one of the things I find really beneficial is finding an activity where I have to have zero thought whatsoever. So whether that's I like to watch Bob Ross videos. I find that's one that I can really sort of dissociate from life and just zone in and forget about my pain. Or
Do you
playing.
mean the painting guy?
Yeah.
Yeah.
So I find activities like that are really beneficial for me, actually, because it doesn't take the pain away, but it sort of clears my mind enough that I'm not really focused on it or necessarily anything else.
I find I call it distraction therapy. It's probably the same as you're getting that I concentrate so much on, for me, it's computer stuff. I find I can spend a whole afternoon maybe correcting old photographs, and you just lose the time. And as you
Mm.
say, it doesn't stop the pain, but you don't think about it. So you're not suffering. I think these days I'm thinking that suffering with chronic pain is a choice. You don't necessarily have to suffer with it if you can teach your mind to change how you feel about the pain, then you get a lot more freedom.
Yeah, I think so.
You touched lightly on you like dance. Do you feel strongly that exercise does help with any chronic pain conditions, that it's important not to just sit in a chair all day?
I think one of the things that I'm a big advocate for is designing exercises for anyone and everyone with chronic pain within their capabilities. So I think it's all well and good for me to come out here at this point relatively physically able. I can run, I can jump to an extent, etc. I can come along and say, well, you should all be getting up and going out for a walk and this, that, and the other. But that's not compatible with everyone. So I think having good relationships with exercise scientists and physiotherapists and developing what programs that suit you, that keep you healthy. And I don't think it's because necessarily exercise helps. I don't think it's ever reduced my pain doing exercise or yoga or physio or anything. It just means that my general health is better. So I'm not at risk of any conditions associated with obesity, for example. I'm not going to get high blood pressure. I may do, but I'm reducing the risk of comorbidities. And I think that was what was key for me because, as you'll well know, chronic pain's bad enough to deal with before you add on any other conditions.
That's it. And certainly when you get to my age and it becomes a long-term condition, you do pick up all these other different conditions to go along with it. And sometimes they become worse than the pain itself. And trying to balance it all is very difficult.
Pharmacologically as well, if you are a chronic pain sufferer taking painkillers, you're then limited in other drugs that you can take because of drug interactions. So it becomes more challenging to treat you, and then you end up on this cocktail of tens of different drugs, which is just a position that, if possible, you obviously want to try and avoid.
Indeed. What's your view then as a young person very early on in this journey of chronic pain? What is your view on the opiate problem? Should these be stopped for chronic pain patients, or should they be allowed but very much regulated?
I think that I like your use of the term the opiate problem because I think that's the first thing I would address, which is removing that title and the stigma associated with it. I think you can see from the States, things like oxycodone have been a massive problem, and the overwillingness to prescribe has caused thousands of deaths, and that's something that I can't dispute. But sensible usage prescribed to the individuals who actually benefit from it, I don't think is a negative thing. I think that there should be more discussion between chronic pain patients and pharmacists and pharmacologists as well about how these drugs work and what their potential side effects are, so that they can then the patient can work with their doctor and try out drugs that might work for them. Because if you don't have neuropathic pain, something like amitriptyline is probably not going to work for you. So you being put on amitriptyline for no reason is a waste of your time, the NHS's money, and it's probably going to be quite physically detrimental. So I think things like opiates for some people are an absolute lifeline, but for some people it massively worsens their quality of life. So I think it's the NHS being more open to trying these things, but also being more aware in the follow-up. So not going, well, we've put you on opiates, so we're going to keep you on opiates. Just putting people on opiates, seeing if they benefit, keeping this dialogue with the patient, and taking them off if they're not benefiting, or reacting accordingly to how the patient responds to the drugs.
Yes, I think I would agree with that. It's pointless just putting people on something and then just not ever seeing them again, or checking up on how they're doing. I think that happens quite a lot, that the current batch of GPs just hand out the drugs and say, there you are, that's all we can do for you, go and get on with it. You're aware of the recent draft NICE guidelines, which haven't gone down well with most people. They seem to be saying to people, right, nothing works for you, so we're not going to prescribe you any analgesia whatsoever. You've got chronic pain, bye-bye. Is that your view of the NICE guidelines?
I think there is a fine line to be trodden between self-management and encouraging self-management and just ignoring patients after a sort of a, well, you've seen this many doctors, so go away, please. And I think that this definitely falls over the line into the latter side. So this is something that I would quite like to work on myself. Like, I would like to try and work with other chronic pain patients and chronic pain groups to try and lobby the government to review these guidelines, because I think that these things do work for certain people. I mean, not removing all analgesia, but just saying to people, there's not much we can do for you. We'll see you once in a while to check in how you're doing, and we'll do what we can. I think that's, for some people, that is the situation that you arrive at. But I think that putting economy over the individual, I think, is just not sensible.
Here in Scotland at the moment, there's a huge drive to move patients onto self-management, but no one actually comes out and says what they mean by self-management. They also don't explain how the patients can access this. To many people, it looks as if self-management is just another word for abandonment, and that chronic pain sufferers, are being expected to pay for this. Therefore, they're being deprived of the free NHS healthcare. So do you think that self-management should then be funded properly under the NHS?
Yeah, I think that one of the things I would really like to see is self-management resources available on a national standardized website for all NHS trusts to do with chronic pain. I think that the lucky dip that you have in terms of your treatment, depending on where you are, which NHS trust you're under, I think is really bad. And I think as well the fact that I know, for example, NHS Grampian are developing a new website with lots of resources about what to expect when you go to the pain clinic. They give you resources of some physio exercises, some mindfulness exercises, etc. And that's a start. And I can access that website as a patient under the Greater Manchester Trust, but I will never know about it without having spoken to doctors at NHS Grampian. So I think having a standardized chronic pain website for the NHS where you have suggestions towards self-management. So you have videos about physiotherapy and how you can develop a regime for yourself. You have videos about mindfulness, about yoga, about coping mechanisms. Because until that point, you're right. If you don't provide the resources for self-management, then it is just another word for abandonment.
What sort of treatments should be available then in a good self-management scheme?
So I think that within the self-management scheme, there should be the opportunity, and it doesn't have to be regular, but the opportunity to have discussions with pharmacists. I think that clinically trained pharmacists, such as those that you'll find in hospitals, could have really beneficial insight into why your medication is doing what it's doing, how it could be improved, whether you need to go up, down, etc. I think there should be better access to physiotherapy exercises, and I think this should be, I really think, an enormous bank of exercises, because I think, as I said earlier on, it's so dependent on what your condition is as to how much you can do. So I think they need stuff from the very lowest level of just doing exercises with your hands or moving your neck from side to side, all the way through to quite strenuous exercise for those people who are trying to maintain tone and physical health. So I think that physiotherapy aspect is important. I think mindfulness is important to have on there. I think this doesn't work for some people. I've never found mindfulness beneficial myself, but I think it's important that people have access to it because I know it does help some people. I think as well you need to give suggestions for what alternative therapies patients might look for. So things like acupuncture, which you're never likely to get on the NHS anyway. If there's genuine clinical backing and there's been studies to say that something is beneficial, the NHS should be saying, maybe you want to try this. So if it's acupuncture, if it's hydrotherapy, and even things that there might be some therapies that you think are just sort of hocus pocus and don't actually help. But even if the effect they have is psychosomatic, that's still a reduction in pain, at least in the consciousness of the patient. So I think suggesting these alternative therapies as well is important, just to give patients the idea that they've not run out of options. Because I think that's something that comes with self-management is this is the end of the road. We've done everything we can do for you. You can do stuff you've already been doing, but nothing new is going to come along. So I think showing patients that self-management doesn't have to mean nothing new is going to get tried, nothing's ever going to help more than it has before. I think that's something that needs to be an idea that needs to be removed.
And contact throughout the scheme, I think, should be important too, so people don't feel they've just been pushed aside and left on their own devices.
Yeah, no, I agree. I think if you can build a relationship with your GP, I think having that contact through your GP is very important. And I think for most chronic pain patients, there should be a push, even in NICE guidelines, to allow chronic pain patients to see the same doctor repeatedly. Because as I said earlier on, if they've not read your notes, you spend your 15-minute appointment telling them about your past, and then they get to the end of the appointment and go, oh, well, okay, go take some paracetamol, go take an ibuprofen, and then they push you out the door. And then if you book another appointment, then you'll go to a practice and they'll give you another GP. So it's just really rinse, repeat at that point.
Joe Parsons there speaking about his life of chronic pain. It just shows that some chronic pain sufferers can still achieve a great deal with their lives, especially when they're young and life hasn't ground them down too much. If you want to find out more about Afasair, please look at our website on www.afasair.org. From there you can join our private Facebook group and learn from other people just like you.